right, we're at a new venue tonight, and Chris will talk us through what's happening with the AMA house later. But just going to check the audio is okay before we start, if that's all right. If we could just have a few comments back from in the chat box that the audio is okay before we commence. Perfect, thank you. So welcome to another webinar. So we're here now, week 10 since the commencement of our webinar series. And I'd firstly like to acknowledge the Kaurna people of the traditional owners of the land in which we're meeting on today here in Adelaide at the Adelaide PHN offices. And I'd like to pay our respects to the elders past and present and thank them for caring for this land that we live on today. So I'm very excited that we've got the team back together. So we're going to make it a fortnightly webinar series just because we're having low numbers of COVID. I'm very happy to answer questions in the meantime, but I'll just go through who's in the room with us tonight. So we've got Dr. Tom Dodd, the Clinical Services Director at SA Pathology, Dr. Louise Flood, who is the Director of CDCB. We've got with us Jane Good, who is from Adelaide PHN. We've got Dr. Chris Moy from the AMA SA President, and Dr. Jenny Gould from the GP assessment team, and myself, Emily Kirkpatrick, from the RACGP SA&NT Council, and also SA Health GP Liaison. So we'll start with, Louise is going to give us a bit of a rundown of where things are up to with the state, and then we'll go from there. So thank you, Louise.
So thank you everyone for joining us again. So I'll just do a very quick update on the epidemiology. So this is the data as of the 12th of May, over 4 million confirmed cases, which is huge, over 1 million cases in the US, Spain and Russia and UK. You can see all the numbers listed there. The ones that have increased significantly recently is Russia, has had quite a few cases and is increasing significantly there, as well as Brazil. But all of the others, increasing significantly all the time, but those are the ones that are having faster increases. Over, well, close to 300,000 deaths, with most of those, the majority of deaths in US, UK, Italy, Spain and France. And that case fatality rate of 7% approximately. And as I've said multiple times, the number of cases detected as well as the case fatality rate does depend on who gets tested and whether you're testing very widely, like we are in South Australia, where we're testing even people with very, very mild symptoms, or whether you're testing only those who end up in hospital. So just looking there at the map, you can see the US is the biggest one there, with over 100,000 cases in the last 7 days. And then Australia, we're there in that with 101 to 1,000 cases in the last 7 days. China has reportedly has only between 1 and 100 cases in the last 7 days. But as I said, this is all depends on testing as well as reporting. So some of the countries likely are just not detecting their cases rather than no cases occurring. And New Zealand also has very low numbers, so they're a good response. This is what the logarithmic curve looks like. So this is looking at the number of cases since they first had 100 cases, the number of days since they first had 100 cases. Sorry, I seem to have cut off the very bottom of the graph. And it's, you can see Australia's there with a nice flat curve now, but US is still going up. And you can see Russia with that quite steep curve there, and Brazil, as I was mentioning, where they've gone quite, continuing to be quite steep. Looking at the number of cases across the world, you can see Americas and Europe are really dominating the graph there, and really not much, still large numbers each day there, rather than any decrease in cases at all. Looking at now the cases in Australia, we're up to almost 7,000 cases there, with 97 deaths. This is as of the 12th of May. The cases in South Australia, we're at for 39 cases, with 300 vials being overseas acquired. As you would expect, the states with large populations do have large numbers of cases compared with us with a smaller population. And also the number of case increases over the past week across Australia, it's been 119, but the daily change percent is really quite low, with only really small numbers of cases occurring, but it has increased a little compared with what we'd had in the week before. And there's the epi curve, so you can see we've had a really amazing response that has dropped right down. But we'll see what happens with the lifting of restrictions and what easing of the restrictions. And in South Australia, we have, as I said, have 439 cases, 300 overseas acquired, 124 are locally acquired where they're a close contact of a confirmed case or are part of a known cluster. And then there's 9 where they're contact not identified. So we've moved 2 of our cases that were under investigation. We've now put them in the locally acquired category. And then we've got 6 who have travelled interstate.
And we've had a few questions this week around the new case that was picked up around the fact that you could pick it up so late after having had onset of symptoms. I don't know whether you wanted to make a comment on that at all, Louise, a de-identified comment about, because we have had quite a few GPs who have had patients come in concerned about those symptoms.
Yeah, so we have changed the case definition, the testing definition over the course of this outbreak. So initially you needed to have travelled overseas and you needed to have an acute respiratory infection with a fever, and it's just becoming more, the testing parameters have loosened such that you only need to have an acute respiratory infection or a fever without another cause, or a change in your sense of taste or smell. So that will change who we detect. So, and also some people may not decide to get tested straight away. They might make the decision that they don't want to get tested, and then the symptoms don't go away, so then they get tested later. So I think in this case, the person wouldn't have qualified for testing if they had got tested earlier.
That's great. Thank you for saying.
If they tried sort of testing earlier.
Yes, and we've also had a question come through around, so I think there was in your previous slide you had in there the cases where there was no epidemiological link. Is that something we should still be worried about as a community here, or are those cases too far back? I know, Tom, you mentioned previously around the new testing and looking at some of those.
So we can look here at our epidemiological curve. So you can see that we did have a bit of a peak, in mid-March there. But you can look that the last case that we had, their date of onset was the 18th of April. So we are going back quite a while that we had our last date of onset. But then you can also look at the ones that are locally acquired when we haven't actually identified where they got it from. They're actually right in the middle of that curve that we've got there. We haven't had any recent ones where we haven't identified where they got it from. So as I keep on saying, there is always, these are the ones that we've detected. We do think we've doing very well with our testing, thanks to SA Pathology there, and now some privates coming on board as well. But we've had very widespread testing, and that's really great. And so thank you for everyone who has done some testing on your patients. There is always the possibility that there's a case or two out there that we haven't detected. So we still need to be vigilant to test people when they become unwell and with symptoms that could be compatible with COVID. But I don't think we need to be overly worried. But we're looking out for it so that we can detect it, particularly with the alteration in the restrictions, so that we pick up any issues straight away. sorry.
Thank you. That's very helpful.
So that's the epi curve. So yes, nothing, looking by date of onset, nothing recent. And then just looking by age and sex, only very small numbers in children, but apart from that, and quite very similar in age and in sex distribution there. So we don't have any current outbreak areas in South Australia. So specifically, the Barossa and the Adelaide Airport are no longer considered outbreak areas. And yeah, just to let you know, it's notifiable. You can notify it online, which I told you before. And just, we do have some resources if you're interested.
Thank you, Louise. I know there's been quite a bit as well through the media around the meat, the abattoir in Melbourne, just out of Melbourne. I don't know whether you want to make a comment at all around that in terms of what SA Health's plan sort of is in terms of testing, particularly at-risk groups, because people are sort of worried, is there sort of pockets in the community that we're not testing? I know, is that something that CDCB is working on in terms of testing and looking at at-risk groups?
So there currently is a national surveillance plan. South Australia is developing a plan. It's not finalised yet, but that is under development. And that's considering the various groups that we would like to test. So we need to make it clear though, the priority with testing is always symptomatic people. That's where we're most likely to get any cases in the people that actually have the symptoms, and the symptoms being the acute respiratory infection, fever, or change in sense of taste or smell. So encourage you to, when you're testing, to test the people that have symptoms.
Yes, that's always a good point, isn't it? Thank you, Louise. I'll just hand over to Dr. Tom Dodd now, who's going to give us a bit of an update on where things are at from an SA pathology perspective.
So good evening, everyone. I thought I'd just show you a couple of graphs of testing across a few countries. The little dot in the far right corner is South Australia's current testing percentage, just over 4%. And the graphs here include New Zealand, which has now got ahead of Australia in terms of testing, and then Canada, the US and the UK. So it just reinforces Louise's point that testing is clearly very important, and we know how things have tracked in each of those countries. So in Australia, once again, you've seen some of this, these graphs in the previous week. South Australia is still continuing to do well with our testing, and I welcome the additional capacity that will come online as the private laboratories here are gearing up or beginning to extend their testing capacity, which is excellent. It'll give us an even wider scope to test more and more patients. I think of note probably is Victoria in the last 10 days or so has really escalated its testing capacity, and whether that's contributed to the fact that they've picked up more cases is sort of debatable, but at least it's welcome that they've been able to really rapidly expand up their testing rate over the last week or so. So I think that's of interest. Obviously, the private laboratories have contributed significantly to that work as well, which is excellent. I thought you'd be interested to see what we're picking up in the general population. So most, but not all, our testing includes a sort of broad respiratory viral panel. As I've mentioned before, at the moment, we do not include rhinovirus. We will move back to having rhinovirus at some point, but we've dropped it to optimising our use of the reagents. But what we are seeing are very small numbers of adenovirus, and then a few other infective agents, a little bit of pertussis, very little influenza, and just a couple of cases of RSV. The denominator for this is about 10,000. So there are a few other agents out there. my assumption would be that the vast majority of people with 30 type symptoms who don't come up with anything on this panel have probably got rhinovirus.
Yes, actually, we just had a question, Tom, as well come through. Is there a possibility of increasing and putting rhinovirus back in? So
yeah,
you've answered that.
We absolutely intend to, and it's been a decision to this point around ensuring we're getting the most optimal use out of the testing reagents and kit, but we're working towards doing that. And I think now that the private laboratories will be cranking up their testing as well, that the scope to do that will improve. You'll be interested to know we had that so-called testing blitz, which ended about a week ago, but notwithstanding that, this week we've seen consistent testing of about 1,500 cases a day, which is excellent. It's right up towards the upper end of what we've been doing all the way along. The sort of the high water mark was just over 2,000 tests a day. So it's very pleasing. Over the weekend, there was, I think, about 1,300 on Saturday and close to 1,000 on Mother's Day. So people are doing the right thing. They're presenting to you to be swabbed, and so we're getting good coverage. So the other thing that's changed for testing in the last week or yesterday really was bringing online this so-called rapid Cepheid gene expert test. So we have these instruments now in all the metro labs and each of the regional laboratories, all 10 regional laboratories. They're very good testing instruments. They're equivalent essentially to any other PCR test, so they've got equal sensitivity and specificity, essentially 100%. The challenge is the number of cartridges available for use. So Cepheid in California manufacture about 200,000 cartridges a month for worldwide use. We've bought a lot of instruments from them, so I think they've looked at us favourably. We're getting about 1,600 cartridges a month, which we are dividing out in a sort of sensible way. So the RAH, being the principal COVID hospital, we're reserving about 50 a week. Each of the regional hospitals have about 20 cartridges for use a week. So about 3 a day. So it's not to replace the routine screening panel, but it's really to assist rapid clinical decision around people presenting with severe acute illness who may need hospital admission in the country and or transfer, and some other clinical scenarios. What we've said to each of the hospital networks are you should delegate a small number of people to be the decision makers about whether a test should or shouldn't be ordered. But I know it'll be really, really important for the regional sites.
And so with that particular test, Tom, is that the one that's then used when there is that domiciliary service out to residential aged care facilities?
Yeah, so if we have a situation where there is a potential outbreak or possible case in a sort of that sort of setting, maybe in a prison or something like that, we would certainly do 1 or 2 swabs using the rapid test, and that'll be a quick way of determining what's going on. The other thing we've already touched on, Louise has touched on, is asymptomatic screening. So we're working through with the CDCB and the department about which groups of individuals might be suitable for targeting who are asymptomatic. Currently we're screening people who are living in the city, in so-called rough sleepers, or people who don't have homeless, and we've screened, I don't know, 50 or 60 people in the last few days. So we're working through those folk, and then there'll be some plans over the coming week or 2 to start testing some other people who are possibly at slightly higher risk, and for them it might be more difficult to regularly access sort of the routine healthcare. And finally, just around the domiciliary service we've mentioned previously, that's been expanded. We now have a larger group who can go out and see patients in their homes or in other facilities. It's easier to contact us. You don't need CDCB approval, and they'll be the group that we draw down on if we needed to do mass swabbing of a nursing home or that sort of facility.
And we've had a couple of questions come through. One's been around how quick is the rapid testing? Tom, I think you've said before 45 minutes. Is that still the case?
Yeah, that's right. It's sort of 45 to 60 minutes. It's essentially, really miniaturized technology. All the reactions happen inside a little cassette inside the instrument, and it's managed. It's amazing to push it all through. It's already available for influenza and RSV, so we do those in parallel with a COVID test.
Excellent. And we did have a question come through around, is the rapid test available on the Yorke Peninsula now?
Yes.
Perfect.
So every place where you've got a regional laboratory, so the mental block. I've got Kabunda, Kadina, and Wallaroo. That's it. Wallaroo is where your laboratory is.
Excellent. Now, it's interesting looking at the data and the breakdown of where the respiratory viruses are sitting. Do you think we've seen an increase at all? And Louise might want to comment on this as well, because we have seen schools going back. Do you think we've seen an increase in just general respiratory viruses at all here in the state?
I can't comment specifically regarding school, but it has been very low.
Yes. Very
low, except the only kick up has been in pertussis, which is not a virus, but that was the only one that has just gone up a little. Everything else was extremely low.
Yeah, I
think those numbers bear that out. It would have been interesting to have the rhinovirus.
Yes, we'll have to put that one back in, won't we, at some stage?
Yes.
And we also had a question around numbers as well, what the capacity was of SA pathology. So if we did see a second wave, what's sort of the maximum capacity of testing, and do you think SA pathology has the capacity to do that? Yeah, so
we were comfortably doing more than 2,000 tests a day at the peak of the, I suppose it was the peak of our epidemic, and we could certainly get back to that without any difficulty. I mean, the pleasing thing is obviously we've got an expanded capacity here in South Australia with the private laboratories now having some sort of expanded capability as well on site in South Australia, and for those labs that said they're working interstate, that also gives us some further capacity. So I think moving forward, South Australia is in a very strong position to be able to actually accommodate any clinical demand.
Yeah, that's very helpful.
I might just go back to the question I just had a moment ago. Yes, I confirm there's the numbers of all the viruses that are tested through SA pathology, the respiratory pathogens are all very, very low at the moment.
That's great, thank you.
No, you can't see anything to do with school holidays.
Good, perfect. That's what we want to know to reassure our parents coming in as patients. Thank you, Tom, for that. That was very helpful to know where things are up to. And as Tom did mention, WinPath is now offering services in terms of drive-through testing at their Myland site, and also domiciliary testing in residential aged care facilities as well. So I know some of you have emailed through about that to me, and hopefully in today's newsletter that explains that both pathology laboratories are offering that service, which is fantastic for our capacity here in the state. So now I'll hand over to Dr. Jenny Gould, who will give us a little bit of an update. You're a bit quiet at the moment, Jenny. You don't have many cases of COVID in the community team.
Well, hello everyone. Thanks for having me back. So I just thought I'd run through the numbers. For those of you, I'm involved with the GP assessment team, as Emily said, and so we have managed the majority, I guess, of positive patients in South Australia through our pathway. Our numbers haven't really changed very much in that fortnight. We've had a few more clearances, but otherwise the numbers are looking pretty stable at this stage. Well, I just thought I would reflect on the benefits of the community pathway and perhaps some of the challenges that we've come across. Having now managed that large number of positive patients, and I guess I have spoken to quite a number of them myself, you tend to get a very good feel for what's going on out in the community. I think the clear benefit of a community pathway is that because this has been a very evolving and changing landscape, as Louise said, our guidelines have changed, our testing criteria, etc. So having a core group of GPs who really can remain up to date has been really helpful, I think, in working with reducing the number of cases and in South Australia. I think it's been well received from the patients, and I guess we're all really enjoying the fact that our flattened curve is continuing, and let's hope that's the case. But I guess if we do see this second wave that the Americans are clearly warning us about, then we've got a skilled group ready to escalate those services if we need them. And there's been no adverse outcomes. I think the relationships between all of the teams that have been involved has been a really positive outcome. And I think including the usual GP in the process is really important as they continue to manage the non-COVID related issues, which is essential. And I think that this process has provided very clear, up-to-date, information in an ever-changing landscape to the best it can. So I think there's been some really positive things that have come out of this pathway. Moving forward, or thinking about the challenges, I think, you know, one of the biggest challenges is this continuing changing set of guidelines, and so it's really important to remain up to date with what's going on, so that if we're going to give patients advice, that we are giving the correct and appropriate advice. And if you're not up to speed with that, then there's lots of resources around, or people you can contact to assist you with that. I think what I've noticed has been, you know, now it's been, what, 6 weeks? Is it only since we began this? It feels like a lot longer.
Yes, it's been just, I think, 7 weeks now,
Oh,
Jenny,
wow.
you've been in the GP assessment team for.
So what I'm seeing with, you know, the vast majority of people is by the time they come to be released from isolation, they're well symptom-free, they're back to their normal self. But there are a small group of patients that have some ongoing symptoms or some residual symptoms, especially around a dry, irritating cough, and this loss of sense of smell and taste that we've talked about. And there's patients that describe this difficulty in catching their breath or having to think about breathing. It sort of almost sounds a bit like an anxiety issue, but these are difficult things to assess over the phone. And so sometimes with these patients, they're going to need physical assessment. You're going to have to review them and examine them and think about whether they need some, you know, there's an underlying other problem like asthma, or whether they've, you know, got a post-viral cough, need to try some puffers, whether they need a chest x-ray. So I think that there's not a small group, but this is a group that we do need to support, because for them this illness can, or these symptoms can go on for quite some time. I think it's really important for our fabulous GPs out there to think about that holistic health. So COVID has been everywhere, and, you know, for the last 7 weeks, but people have pre-existing medical issues. They've got comorbidities, they have developed new problems during this last couple of months. So all of these things, it's really important that they get continued to be managed. We need to still be thinking about monitoring our chronic health conditions, diabetes, blood pressure, you know, preventative health, so cholesterol checks, smears, breast checks, vaccinations. So all of these things can't really stop. And I think there has been we know that there has been a reduction in numbers of people presenting, not only to the GP, but to hospital, and, you know, people staying at home and having the infarcts, and really less than ideal situations where we have, you know, medical expertise at hand. And I know that that's fear, and where there's fear, there's paranoia, and everybody's really worried about presenting to the doctors, because we are the cold face of, you know, and seen as the virus carriers, the scary monsters. But I mean, I think it's really important to encourage patients for their regular medical review, and to seek help if they are finding themselves in an acute situation. And it may well be that, you know, you're needing to look through your notes to look at who are your patients on care plans and chronic conditions, and making contact with them. Obviously, it's really important to avoid face-to-face in the setting of potentially positive patients. But it is still important to manage face-to-face consults. And sometimes there is a limitation to telehealth, and that's why we haven't always used it. And so it's fantastic to have it, but don't be frightened to do face-to-face consults. We still need to provide those services. And if you're in a situation where you're not able to or comfortable to as a GP, then there are GPs around, and we really want patients, if they're needing that assistance, that they get that. So, and I think this brings me to my final point, and I think this is the most obvious thing that has become apparent to me, is this ever-increasing burden of mental health. People who have been cleared from or released from isolation, over a month ago, still are reaching out to me with being unable to get out of bed and anxiety about being contagious or it coming back. And I think this is something that we're going to see more and more of as we move forward. So it's not only during the time when people are positive and in isolation, but it can often be after they've recovered. So I think GPs are very well placed to provide that mental health care support and for patients that they know well. And I would really encourage you to turn over that stone and ask those tricky questions with patients, because it is really apparent in the people that I have had ongoing contact with. Now, obviously GPs are great at mental health, we do that, but if you're in a position where you find you can't do that, or you haven't got the resources, or it's not your area of expertise and you've got someone who's struggling, look, please contact me or Emily, and we can provide some assistance around that. So yes, I think that's me done for tonight. So thank you.
Thank you, Jenny, and thank you for all the work you've been doing. I know you're still calling up patients and checking on them, and because it is a really big issue, the mental health effects of COVID. And I know we'll see more and more papers coming out in the literature around this and the anxiety, particularly post-isolation. We did try at SA&NT to get some communication out around that anxiety, and that it's okay to go to the shops, because we'd had some stories and that had come through, particularly from GPs, have said that the patients weren't able to go to the pharmacy or other things post being released and having a clearance certificate. So I think we will definitely see more of that, but it's a shame, unfortunately, that comms didn't get out there because of priorities. But particularly if we do see a second wave and larger numbers, then it is something we need to be really conscious of, that once the patient is cleared, it is okay for them to go to the pharmacy and get their medication and see their GP and maintain social distancing. So thank you, Jenny, for all that you've been doing in that space. I'll now hand over to Dr. Chris Moy to give us a bit of an update. And I've got a few questions around telehealth for you, Chris, as well.
So just a bit of a short one, this one, because we've had a few things going on in my life. Can I just make a comment about going... there really does need to be pushed back, people going back to see their doctors face to face. I mean, I personally, despite my reduced clinical load, have had to take on 2 patients from other clinics who basically closed down face to face and picked up diagnosis of cancers in 2 of those patients. And one of them probably makes a big difference. So I think it is actually a real thing. It's not made up. It's going to be another pandemic if we don't get on top of this. So it is important.
And we've got June is Bowel Cancer Awareness Month as well. So we're hoping that people will give a bit of thought around screening programs and trying to get things back on track as well for their patients.
But it is a real thing. So there's quite a push on, and certainly I'll be pushing on, and SA&NT are definitely pushing that on. We're going to get much bigger. The balance of risk has shifted right at this moment. So I'm going to nag about, bit of formatting. I'm going to nag about Health Pathways South Australia again, because again, it's just really for the future, this is the way we're going to go with a lot of initiatives, I think, and SA&NT have definitely got that message now. And it has, as I said, the links to COVID information, but also all those other protocols which have come out in other areas now for COVID, because everything's COVID now, asthma COVID, obstetric COVID, yourself, everything's COVID now. So there's links to those clinical guidelines. I was just going to make a point specifically about industry code for visiting residential aged care homes during COVID-19, which was released last couple of days. So that's come out because of the tension understandable tension has occurred with respect to the aged care facilities and the visiting, mainly to do with visiting for aged care, for patients of the aged care residents. Now, I think I've understood both sides of the argument, because I've definitely had desperate calls from aged care facilities with respect to some, especially early on, some pretty dicey behaviour by some families coming in from overseas, particularly, and you know, I think Newmarch is a salient case about what can happen in aged care facilities, because they basically are ruby princesses, stationary ruby princesses. The second thing is that there has been a rights issue as well, and I totally understand that, because it's very difficult for families and also individuals who have dementia to have their rights protected by substitute decision makers. So, so this, if you've got family members who are getting upset about this, this is now the kind of agreed, and it's been agreed between the aged care facilities and consumer groups as well. So I think it's quite a good balance. I mean, it's not, nobody's totally happy about it, but I think it's a good place to start. So if you've got a query about it, I'd go to that.
And thanks for bringing that up as well, Chris, because this is obviously a big point around what would happen if we did have an outbreak within a residential aged care facility, or any facility for that fact, which has residents within it. And we're certainly looking at that at SA Health. I know CDCB is looking at that. We're looking at it from an out-of-hospital stream at SA Health, and also taking into account the rural aged care facilities as well, and how they would deal with having a positive patient in their facility, and would that require them to be transferred out. So we're just having a look at that in that process. We've obviously gone through that, all the talk around the 7 steps pathway, making sure they've got an advanced care directive in place, but we also have to balance the public health need as well and take that into account. So that's something hopefully we'll have some communication out by the weekend on from SA Health perspective.
Great. I was just going to tell you, this is why I've been a bit busy. We had a little fire at AMA South Australia, so we're out of the building, unfortunately. So somebody lit a fire under our building, so it's destroyed the entire bottom floor and the basement, and it's smoked us out, so we're out for 12 months. So, but can I just say, I brought this part because Emily said you need to say a little bit about this.
I want to share. I think it's really important.
Yeah,
We've had people contact us and say, and it is really upsetting. People think about all the woodwork inside the AMA, all the history as well.
So the actual top level,
okay, Chris?
The top level is completely soot and smoke covered, but it's not damaged. So the paintings and the historical items are actually going to be okay, but everything has to be clean. And there's structural damage at the bottom of the building most likely, and they'll have to rebuild the bottom of the building. So we are out of there for 12 months, it looks like. So yeah, it was pretty, a fair bit of damage for a relatively, that fire started on the right there. There were some bins there, and they lit these bins, which just happened to be next to the air conditioning vents. So the smoke went straight up in there, and the flames actually went through the air conditioning vents, destroyed the first level. You can see that. That's actually the dermatology unit. So that was completely wiped out. And then the second floor was completely water damaged, and our floor was completely smoke and soot damaged. And Newland House, who you may know, which is actually on Braun Place, is completely covered in smoke, and nobody can work in there. So it's everything has to be cleaned. And so it's going to be a 9 to 12 month job. So we'll be finding some new rooms for a while. So that'll be interesting. But can I just say, I want to show this picture because I want to thank my staff who have been fantastic. Sam Mead is the CEO, and Claudia Baccanello, who's an amazing EA who's been with us for so long, and people who know the AMA will know her. They were there today cleaning up, and they've got such a positive attitude, and they've just kept going. And I just wanted to say that really, just to a great degree, that's been the spirit of what's happened in South Australia. And I think that that's a really important thing. And the thing I wanted to bring on from there is the fact that next week I have to, and I'm sure you guys will have to do it at the parliamentary inquiry at some stage. You'll be turning up. But I've also had to put priorities from health, from Chris McGowan, some of the learnings here. And I have to say that the sort of learnings that I will put is the fact that this new collegiate non-silo thinking between, and greater respect between SA Health, the hospitals, GPs, and all the is really where we need to go. We need to stop thinking this silo. We need to stop complaining about each other and actually listen to each other and do something together. And you know, the work of Emily and Danny and Jenny here have been really amazing. Really, you need to understand how hard these guys have worked. And so I think that's the future for us, and we need to embed that. Now, if particularly if you're AMA members, but if you haven't, if you want to write letters about that, can you write them to AMA? Because I'm not joking, if you send some emails in, I'm going to flick them at the parliamentary inquiry and say, for God's sakes, keep this going, because this needs to be the future. So if you want to do any of that, if you could help us out with that, that would be helpful, because I think, I mean, to me, I think even when we're walking, this is, I mean, look, we're always going to not all agree about everything, and that's reality, but that's different from actually working together and actually getting the job done, which in South Australia we really have. So well done to everybody, and I put that up there, really, the fact that we put up with a fire, but frankly, I'd rather have the fire and have South Australia safe than the other way around. So well done to everybody out there, because you've been very, very much part of that. So, and
right back at you, Chris, it's for all you've been doing from an advocacy point of view. You've been constantly out there on the radio, in print, doing so much for South Australia and in the AMA space. So thank you so much for all of that.
Oops,
now,
sorry, I can't do that.
I'm just going to move that onto here. Now, we've got a few things I want to talk about. One was around, was just in relation to telehealth item numbers, Chris, and whether you thought there would be any sort of, we talk about September, we're already getting a few questions in with the low numbers, how would that work for this state and for the country in terms of the telehealth item numbers? Do you think they're going to continue on? What's the plan from the AMA perspective?
So the history, the politics of it is that the department have always, so I was back there a long time ago when the original rural ones, right? But they've always risked as silly, because they always felt that we GPs were going to abuse them, okay? And we were going to abuse them and use them for everything and not use them appropriately. I think part of the problem initially is that we had to open up the criteria a fair bit, so they were for any patient, and also so what will probably happen, as I suspect, is in the initial opening up of criteria to any patient, irrespective of whether they've actually seen a doctor at the practice before, within a certain period, is probably going to be restricted at some stage, but look, my impression is, and I would be getting into every stakeholders, I was actually a speaker at a Consumers Health Forum and discussion about telehealth, and I've got to say they are really strong for it now. So they'll become probably our greatest advocates, because they'll be our advocates. But the thing is that it'll probably come back in a different form after September.
Yes, and knowing where those face-to-face consultations sit in that as well.
Yeah, and we'll probably have to progress the technology. What I mean by that is the technology will have to be both sides. It can't. I mean, phone is one thing, but the reality is that video is better, and I think probably we're going to have to. Because of our lack of preparedness, we didn't have a well-accepted technology for video conferencing that was at both sides of the communication side that was secure and accepted. So at the moment, there are some out there, but they're still not widely enough accepted. And, so really where we're going to have to be is have something out there that can work. So a patient out there who's elderly can cope with it with their smartphone, and we can cope. And it'll be restricted probably. My guess is it's going to be you have to have seen the doctor, or later there'll be some issue about whether you're part of a nominated practice or something like that.
Yep.
To be able to do it, which is probably the way it should be.
Yeah, but it's not going to disappear altogether.
No. There is. Look, I can tell you now. Inside the department, if it was about money, they would kill it now. Okay. So, but they've always resisted this. You need to understand that. This is why I've said all along that we need to look after these item numbers and treat them with respect, because at the end of this, we don't want them to come back to us and say it was completely abused and throw it out the window. So I don't think the people on here are going to be one, but we just need to really treat those items with respect, please.
That's exactly right. We've had a couple of questions come through. One's around the respiratory clinics, and talking through what the process is for the respiratory clinics and examining patients as well. And I mean, I've tried to communicate this out, and look, I'm very happy to have a discussion about it here in the room as well around the role of the respiratory clinics. But certainly it's designed to assess patients who do have respiratory symptoms and provide a swab for those patients. And there's been a bit of back and forth around, well, are they fully examined in the clinic? How does that work? And we know it does vary across the respiratory clinics. We've now got 9 clinics, so 4 here in Metro and
Can I just say,
Yeah,
look, again, I don't have a conflict of interest because the clinic I work at actually has one, but can I just say, I had to have a test at one last week, so I did the right thing. I had a bit of a sore throat and I had a bit of aching one day, which is probably because my wife decided to, sorry, Monica, you gave me a Boostrix the day before, so I wasn't feeling that good, so I couldn't go to work, so I went to have a test, booked with the respiratory clinic, had to fill out some forms. So the process is you have to fill out something you can fill it out online, and then you have to go to the government website, fill out some more details, they'll approve you, they send you a text, and then what actually happens then is you need to go there at a point in time. You walk up, you go in, you actually go into a specific room where initially you'll be taken into a specific room which has been cleaned, completely off. It's very, very bare, let's just say. And then a GP will come in and actually take a history and examination. They can actually do the history from further away over the phone through a telly first, and they'll come in, then they may examine you depending on what they need to do. It obviously depends. If you fit the criteria, then basically you go into another room and the nurse will come in and do a swab. It ain't as bad as it sounds, it's fine. And you have the swab, and then you go, and the test was back by the next morning. I had it in the afternoon. It was very impressive.
That's right. And I think there's that thing around the examination and when that occurs. And it's from my understanding and from correspondence through the PHN as well, it is if they are displaying abnormal signs. So abnormal respiratory function, or if there is a clinical concern, it is a child, they will be examined. And that is listening to the chest, checking that they're okay and going from there. It is very hard because these clinics are constrained in terms of appointments, what they need to do, auditing, things like that. So there is that need to be able to see patients at a relatively fast pace and also maintain appropriate PPE and not go through PPE at rapid pace. We are here at the PHN offices, and I have seen the huge room full of PPE. I've been eyeing off the N95 boxes. I've seen them in there. So just, please send through your request from the PHN to supply you with some PPE.
The EOI form is on the website.
It's on the website. So yes, please put one in, and do know that the PHN is here to support you for your PPE needs, but you do need to put an EOI in. And we do know that stock is coming back on. And I know a lot of GPs have been working so hard to get their PPE up and have been putting in some big orders and things like that. And it is so important that we do have the PPE. And I think when we look back and see, well, how is general practice done from the COVID perspective? We're going to be all talking still about the PPE and how that was one of the biggest issues for general practice to be able to perform on the front line was not having the PPE available. And we did have a question come through, and Louise, you might be happy to answer this around if you are required to test someone who is asymptomatic, so perhaps that's part of that sentinel testing program. What's the sort of PPE requirements for GPs for those situations? Do they still need the full PPE?
This is something that hasn't really been agreed nationally, but I would think yes, that they would need the same PPE, because you have to sort of think what happens if they are positive, and then you would then become a contact, even though it's not expected, but and it's not worth putting yourself in that risk.
Yep, absolutely. And we do know of GPs who have had to take their 14 days because they've been incidentally exposed. Just a question as well for you, Chris, around, do you know if the respiratory clinics are checking ears? We've had a question come through around ears. Did you have your ears looked at, Chris?
No, I didn't, and it wasn't a symptom. But what happened was walked in, temperature, oximetry, history, examination, but ears, I think it's possible, but I didn't on this occasion. I couldn't explain that.
Yes, so, and I'm aware of some clinics that are not examining ears. So but I think it really does depend on what the respiratory issues are and how that clinic is staffed and function. So as I was saying, there's now 4 clinics in urban Adelaide and then 5 in rural regional areas, which is really fantastic. And those clinics will continue seeing patients throughout the winter months, and we might see rhinovirus back on the SA pathology panel as well, which will satisfy many, which is great. In terms of examining kids, we've had a question. Yes, they do examine kids, and that is an issue around ears, isn't it? Because often we do see respiratory issues accompanied by otitis media as well in children. So that's something we can find out and see whether ears are being examined. So thank you for posting that question as well. The other area we've been asked about is now that some GP clinics are transitioning back to face-to-face and doing more face-to-face consultations, how does that work in terms of the waiting room setup? And so in particular, we know there was that 1 person per 4 metre square rule, just to emphasise that that doesn't apply for healthcare facilities as part of the direction. So do keep that in mind, but you do need to maintain, where possible, 1.5 metres of distance between you and the patient, or between patients in your waiting room. So it might just be worthwhile thinking about that as well. In terms of, so nurses conducting care plans, for instance, just reading a question that's come through around that, do you need to wear a mask when you're seeing the patient and partners attending? Look, the advice on that has been to, and the RACGP has done a lot of work putting out advice on this as well, has been to try and avoid other people being in the room where possible. So this applies as well for interpreters. So where possible, using phone interpreters rather than in-person interpreters, and thinking about not having additional members of the family in the room. This has been also the case in aged care facilities as well, and limiting that potential exposure. So thank you, Angela, for posting that. I don't know, Louise, if you had anything to add at all around, having, more people in the room. Is that something that you were concerned about as well in terms of contact tracing and prolonged exposure if you're having multiple people together?
I think it really depends on who they are. I mean, as in if it's a household contact, they would have already been exposed, and it doesn't really matter. As in if it's someone who lives in that household and is currently being exposed, it probably doesn't matter, parent-child type thing. But if it's anyone who's not, then I wouldn't. It's better just to see the patient.
And if you are seeing the patient for a prolonged period of time, say an hour, there's a question around, should the nurse, for instance, who's doing the care plan, should they wear a mask at the time when if it's going to be more than 15 minutes if they are worried about exposure?
I don't think it's necessary. We've got a patient who doesn't have, it's very different, obviously, if they have symptoms of COVID, that's different. But if you have someone who doesn't, and they're not in one of the high risk groups, as in they haven't just got off an international plane or something like that, then I think you just keep your distance from the person, so you've got more than 1.5 metres whilst you're having that discussion.
And it's, I guess it is one of those things, isn't it, really, that you should be screening patients before coming in. Hopefully now we're not getting people who do meet those criteria, because people have come from overseas, hopefully are doing their quarantine as required, and interstate as well. But it is something to be really still thinking about, because we do still have the essential travellers coming over as well, that screening is really important. And you may have noticed there was that change in the direction around keeping a log of contacts. So hopefully that'll be helpful as well from your perspective, Louise, as well, with the logbook.
Yes, and obviously the other thing is the COVID Safe app. So if you consider, we recommend you consider downloading that yourself if you haven't already.
Yes, and think as well about if your patients do ask you questions, there's some really useful resources online for the COVID Safe app, and particularly if they're already downloading the Medicare app for their immunisation, so that then they can go and visit their family in residential aged care facilities, for instance. They can think about downloading the COVID Safe app at the same time.
Can I just say, a lot of people actually have forgotten. Like, I was on this consumer group the other day, and it was about 200 or 300 people on this consumer group. It was quite obvious a lot of people were on there saying, oh, that's okay, I like it, but I'm not going to do it till I come out of lockdown. The thing is that they're going to forget to do it, so I'd actually be reminding them to do it, because it's like they were doing, I'm staying at home, so why do I need the app? And you're saying to them, you've got to go out. Once you do that, don't forget to do it. The other thing is that I really have this issue with I think part of the problem has been the fact that there's been misunderstandings about it, and it's the panacea. It isn't the panacea, but the way I've tried to explain it is that it's an extra tool that helps a bit. And, even if only, say, 30-40% people download it, and if you get a situation where each person passes on, 10 to, one COVID case who's a super infected passes on to 10, you can knock off 3 branches of that from that person. You actually make Louise's job a great deal easier at that point in terms of hunting down the others. You close it down a bit. So I think, you know, like, I just think people think that it's the panacea. It isn't, but it's helpful. And I think we should be reminding everybody to download it.
Yeah, I might just say a couple of points about it. So basically, I don't know how much people know about it, but it basically, if someone has been in close contact with someone if two people who have been in close contact for 15 minutes in a row, then that will be registered in the app. So no, it registers it all the time, but if they're the ones that will be registered as having been a close contact. So when we get a case, when we're interviewing the case, we ask them if they have the app. If they do, then they then have to, they have the choice to have their data uploaded. If they don't want to do it, then it's up to them. They don't do it. So they do have. Even if you downloaded the app, and then if you become a case, you still have that choice about whether you want to upload that data. And if they do, then that data, we get a list of those people that have had the 15 pings in a row, so thought to be within that 1.5 metres and for 15 continuous minutes. And then the idea is that we contact those people. And we can't, there's a whole lot of, there's an agreement about it, so that we can't give the name of the contact of the case to those people, and we can't, only certain people who have approved can see that data. So you have to do a training and that type of thing, and sign something about it to say that you want to use the data you need to. Actually, I don't think sign anything, but you have to do training about it so that you know the rules around it. The idea with it is that when we interview a case to find out where they've been and who they've been in contact with, they'll be able to tell us about their family and who they've had, if they've been out to dinner with someone or whatever. But they might say, I went to the hardware shop and I was there for an hour, but they don't know who they were near in that hardware shop. And if they happen to have, been very interested in buying nails and someone else was very interested in buying nails as well, and they took a long time to buy those nails, they won't know who that person is. But if they both have the app, then we'll know about that person, we can follow them up.
And I think that is a very good point, isn't it? It's we don't have the contact details for those people in the hardware store, do we? So when CDCB, when you're doing all that work with contact tracing, it's very hard to say, I did see a man with his red shirt on for the whole time I was there looking at the nails, but don't know his detail. Maybe they should be friends anyway if they're both looking at nails for that period of time.
Is it actively used in the States? Do you know as yet?
I'm not sure about interstate. The agreement, well, we signed it on Friday. So if we have a case, we can get that data. I'm not sure whether all the other states did or not.
Oh, so that's good to know that's now that option is now available for SA to use.
Yeah, so which is really back to Chris's point, just really encouraging you to download it yourself if you haven't already, encourage your family to do so and your patients. And there's information about the privacy and things when you do download it that you have to agree to if you're happy to.
Yeah, that's excellent. One final question that's come through is around when is it acceptable to start doing 75-year plus health assessments face-to-face again? I guess it really does depend on what your clinic setup is and whether you can do, you can separate that visit out in terms of time exposure, what you usually do as part of your 75-year-old health assessment, and will that be done as part of immunisation at the same time, other opportunistic care as well. I don't know if anyone else wanted to make a comment on this, on those sort of resuming face-to-face long consultations again. And what the thoughts are on that in terms of how do you manage that? It is really important people still get the care that they need, and that is something that worries us.
I mean, the sort of options you've got is to try to, this is where it does get tricky. You can try to break it up into telehealth and then you do the physical examination. That's one, where particularly there are a whole lot of other issues we dealt with telehealth. Now, and you know, you have to do examination a few days later, possibly. I mean, yeah, you know, and that's one possibility. The other sort of possibility is if you've got enough room in the practice, then you basically do the physical distancing within the consulting room for most of the consultation, which can still happen. I mean, I have a seat and I have a line 1.5 metres away from me, and the patient's sitting there. And obviously, if it's a person who is at risk, I'm actually still going to wear a mask, and they're going to wear a mask. And I'm going to wear a glove if there's an examination and to treat them. I mean, I think it's mostly common sense, really. I think because then you've actually complied with the physical distancing aspect. Obviously, you're still in the room for a long period of time. That's the problem. But you know, most consults aren't going to be an hour, at least at this stage. But I think my view would be you just have to think it out, and a lot of those long consults may need a little bit of pre-planning. That's all.
Yeah, and exactly right. It is thinking through and planning and sort of deciding what's going to work in your situation. We're coming up really to the end of time. I just thought I'd just very briefly, because I always get asked this question about what's happening with international arrivals and where are things at. And so I think people sort of thought everyone's sort of gone home after we had our 2 large flights that were repatriated from India. Currently, we do have just over 20 people in quarantine here in South Australia who have come through on exemption for essential reasons in terms of compassionate grounds and for other reasons as well. And so they are currently in hotel accommodation here in South Australia. So I just thought that would be something that we get asked about, you know, what is happening in that space. And there is a process for applying for exemptions if you do meet those criteria. And then the other thing I just wanted to very briefly touch on and to say was thank you so much to everyone who has done so much work in this space. You know, Louise, Tom, Jenny, Chris, you've all been so amazing. You've answered all of our questions via email. You've been coming in weekly for our webinars. And I just want to say that was the last thing I wanted to raise is we are so grateful because we couldn't have got to where we are here in South Australia without all of your support and all of your hard work and hours. And I think we definitely need to go to fortnightly webinars because everyone's exhausted. And so I'm just so grateful. So thank you so much. And a big thank you to Adelaide PHN for allowing us to host the webinars and for having us here tonight as well. We've got to come into your fancy offices. I may sneak into the stock room for those N95s. No, maybe not. I better leave. I've said this is going to go online. But thank you so much. And we'll see you in a fortnight. And please keep sending through your questions. So good evening.
Yeah.